Hi everyone, welcome and thank you all for coming to tonight's presentation, where we will look at 4 very important studies and the impact it has on our day-to-day practice. My name is Willie Garnawan, I'm tonight's moderator, and this is a Bosch and Lomb sponsored event, and it does attract 3 CPD points. The link to the questions should be on your confirmation email, and you'll have 2 weeks to complete the questions. Tonight's presentations will also be sent to Ion CPD for CPD recording purposes. So for those of you that doesn't know Joseph, he's the principal ophthalmologist at Melbourne Eye Centre. Joseph has done glaucoma fellowship in Sydney and is currently a senior consultant at the Royal Victorian Eye Hospital. Joseph was also the head of cataracts and trauma clinic at the Eye for 5 years. Joseph was one of the first in Australia to be certified to implant the eye stent, the Hydrus and the Zen gel stent. And he is, or I should say was a big supporter of the FEMCAT laser cataract surgery. We'll hear about that later. Joseph is a very strong supporter of optometry. I've known him personally as a lecturer and teacher at Melbourne University and through our interactions with glaucoma co-management patients. Tonight, Joseph has recorded 3 presentations discussing each study and is now joining us live to answer any question you guys have. Feel free to type down the questions and we'll go through them as many as we can tonight, and Joseph would be more than happy to answer the rest on email if it's required. So without further ado, I'll pass this on to Joseph.
Okay, thanks, Will. Thank you to all those that have joined. Tonight's 3 topics, well, they're actually 4 topics, but 2 are rolled into one, are going to hopefully give you information that you can use in your day-to-day practice. There's going to be a very short pause between each presentation to allow for questions, which Will's going to moderate. And each of these topics have been selected from pretty much the work that I do, which is cataract, glaucoma, and refractive. Just as you are, I'm sure, all aware, although the question and answer sessions are live, the presentations themselves are actually pre-recorded. Okay, so without any further ado, I'm going to now mute my audio and my video, and we're going to go to the very first presentation, which is on the light study. It's not the only study that I'm going to talk about, but it's essentially the main study. So let's have a look at a patient example. Let's suppose for a moment that you're sitting in your consulting room and you've got a brand new patient that you've not met before who tells you that they've got a family history of glaucoma. And the main thing that you find when you examine that patient is that they've got an elevated pressure to 29. And essentially the rest of the examination is pretty much unremarkable. So they've got normal optic nerves, you run an OCT and a visual field, and there's really nothing to find. So it's just an isolated, elevated pressure. And of course, it goes without saying that you're going to repeat that a few times to ensure that it's a real measurement. So the question becomes, what do you do? And there's a number of different approaches that you could take. So we're going to go through each one of them in turn. So the first thing is you could just do nothing at all. You could decide that it's an aberrant measurement and you found nothing else. So you're either going to not see the patient or maybe you might get them back on another day. The second thing you might do is decide that that pressure is pretty high and you've confirmed it. So you think it's safe to treat them and then you're going to refer them on. Alternatively, you could decide that you want to hang on to them, so you might treat them, and then you might get them back and you might just manage them. And finally, you might decide that you can't be bothered, or it's not your thing, and you want to refer them on and let somebody else deal with it. So to try and answer the question of what we should do, we look at the light study. So the light study is laser in glaucoma and ocular hypertension. And this study posed the question that in a brand new patient, so never been diagnosed, never been treated before, is it better to treat that patient's pressure with SLT or with pressure lowering medication? So this is the study, and this study was published recently online in March of last year. And in addition to that study, there were a number of spin-off studies, which I'm going to refer to, such as this one here, looking at the repeatability of SLT. And also this study, the SALT study, which is looking at the role of non-steroidal topical medication after you've done an SLT. Is there any benefit in doing that? Now, in order to answer the question, what the study did is they randomized 718 patients, and 356 of them got SLT, and 362 of them received topical medication. So what did they find? Well, the first thing they found is that more of the SLT patients were to target at the end of the study than patients on topical medication. Now, the difference was not that enormous, and you could argue that both treatments are efficacious, but there was certainly an advantage to the SLT patients. The second thing that they found is that more patients who had topical medication progressed than those who had SLT. Now, again, the difference was not enormous, but again, the SLT won out. The final thing that they found is that when you look at that group of patients, none of them in that study duration period required any surgical intervention, whereas 11 in the topical group needed further intervention. By that, I mean trabeculectomy or something like a trabeculectomy. The other thing the study looked at is the cost effectiveness. Now, the cost effectiveness analysis that the study did was applicable to the NHS system, and obviously our system's different. So I'm not going to present their findings, but instead I'm going to talk about my findings or my estimate of it all. So an SLT in Australia cost $390 roughly per eye. This is the cost to the government, not the cost to the patient. The cost to the patient depends on who you refer them to. So that works out at $780 for both patients. And so that works out to be $260 over a 3-year period. Now, let's do a little comparison with treating them topically. And I'm going to choose latanoprost or Zolotan because it's one of the cheapest medications around, and also because it's probably the most commonly used. And obviously this analysis will vary if you put in something else or if you include multiple medications. So based on that assumption, that works out to be $847 over 3 years, which compares with $260 over the same period for SLT. So there's no question that SLT is definitely more cost effective. Now, quality of life is the next thing that the study looked at. And the study actually admitted that the quality of life questionnaire that they used was really not geared for glaucoma. And so they actually don't really believe their own findings, but they actually found no difference between the two treatment approaches. However, what about the hyperemia that the patients get? What about the loss of orbital fat? What about the dark circles under the eyes? What about the irritation, the non-compliance, the patients who didn't remember to put their drops in? What about when they went traveling and they forgot to take their medications, etc., etc.? So I think you would have to agree that even though the light study found no difference in quality of life, there clearly is a huge advantage to having SLT versus medication. The study also found that there was a lower rate of cataract formation in the SLT group, which is, I guess, intuitively obvious because we know that topical medication used long enough will bring on some cataract formation. So given those findings of the light study, what about our patient? So let's have a look again at our choices. So watching them, and I think nobody here would leave a patient with a pressure of 29 untreated. So I think that's really not a very good option. What about the option to treat them and then refer them on? I think that's really not a good option because I liken it to a crime scene. If you have a crime scene and people start stomping through the crime scene, they're going to contaminate it. So I consider this as dirtying the crime scene, and no ophthalmologist likes to see a patient that's been partially treated. It's really best that if you're going to refer them, please do not treat them. Leave them untreated so that we can see them in their natural state. So that's not an option. What about treat and not refer? I think that that's really not in the spirit of co-management, and co-management guidelines, as far as I'm aware, still are in place where if you have an emergency situation, you should treat them, but otherwise you probably if you decide to treat them, that you should probably refer them on within about 3 months. So I think, again, treat and not refer is not really a good option. So therefore, it comes down to the fact that given the findings of this study, the patient really ideally needs an SLT. Now, let's look at some exceptions to that rule. When are you not going to follow the guidelines for the light study? Well, firstly, if you've got a patient with a very high intraocular pressure, I think unless you can get them seen that day, or unless you can get them seen within a day or so, a very high pressure, really, you should start them on treatment. Similarly, if the patient's got very significant disc damage and or field loss, and you think that they really shouldn't be left any longer with such high pressures, again, unless you can get them seen on that day or within a day or so, that's another example where you may choose to treat them and then maybe send them on. And finally, of course, if you've got no access to SLT because maybe you're in a rural area and there's no local ophthalmologist and you haven't got much option, then that would be another scenario where you probably need to treat them. Let's also look now at some practical points from the studies. The first thing is that we used to think that it takes about 6 months for an SLT effect to kick in, but the reality is it really only takes 2 to 3 weeks. There's also a percentage of patients who are either non-responders or partial responders. And what the follow-up to the light study has shown is if you treat those patients with, say, a second episode of SLT, you're going to get a lot more responders and you're going to get potentially a bigger fall in pressure. The other thing is that they found that on average, most patients with SLT get about 3 years duration before it starts to wear off, with a range from about 1 year through to over 10 years. But the study has also found that it's repeatable. So if you come back, say, after 3 or 4 years when the SLT effect's wearing off, if you repeat the SLT, you're going to get equally as good a result in terms of amount of fall, and you're probably going to get a similar duration of action. The study also found that about 75% of patients roughly were medication-free at 3 years. The other thing is that the follow-up to the light study did find that if you use non-steroidals following the SLT, you get an apparent improvement in outcomes, although there's been some criticism of that study, and that perhaps is not so for sure. And in fact, I've actually stopped using non-steroidals following it. So the final conclusion of the light study was that SLT should be offered as a first-line treatment for open-angle glaucoma and ocular hypertension, which is effectively a change in how we approach these sort of patients from what we previously used to do. If anyone's interested, there is a very good podcast from the American Society of Ophthalmology, which is the As Seen From Here series. And there's an interview with one of the study coordinators who talks at length about the role of SLT, how they did it, what they found, what happens when you repeat it, and so on and so forth. And that's quite a good listen that will help you to make decisions about your patients. Okay, so having gone through it, I'm now going to go over to Will for any questions.
Okay, so it doesn't look like there's any open questions, but I've got a few ready to go, Joe.
Okay, yep.
So seeing that there, so you mentioned the cost to the Medicare, but there was little mention in terms of cost to the patient. I know that different practice will charge differently, but what would be the cost to the patient in your practice?
Okay, so there is a big variation, and you would expect, or you would hope that there is a big variation because it's a free market and people can charge what they like. So I can only tell you what we charge. So our cost is $550 to the patient. So because they're getting roughly $390 back, they're only about $160 out of pocket. So that's per eye. So effectively, that's sort of equivalent to about 1 year's worth of medication, on the assumption, of course, that you are paying for the medication out of your own pocket. If you're a pensioner, the equation is different because pensioners don't pay as much. So a pensioner will take longer to get their money back, so to speak, or to be at least equivalent than somebody who's literally paying it out of their own pocket.
And what happens if the treatment doesn't work and you need to retreat within a few months? Would you charge them again, or is that?
Okay, so again, the protocols are going to vary from practice to practice, but in our practice, what we've decided to do is if SLT is going to be the way to go, we say to the patient, we're going to treat you, one treatment per eye. And if you are either not a responder or you only partially respond, we're going to repeat it as many times as is required to get you to respond or to lower your pressure to target, but we will not charge you any further. So they only ever pay once. So what we do, obviously we don't wear the cost of it. We simply bill Medicare. So the patient only ever pays once. Now, if they come back at 3 years or even 10 years and they need a repeat, that's a different story. We haven't formulated a policy there, but I would guess probably we would go through the process again, recharge them, but only once.
Excellent. And I know the study shows that this should be considered as first-line treatment. So is this now your first-line treatment? And would you say that other glaucoma specialists take the same view?
Look, again, I can't speak for other people, but I think the light study is pretty clear cut. The number of benefits, as you've seen from my presentation, is enormous. And it's a case of we need to treat our patients with the best evidence available, which is currently the light study. So I now offer my patients, with exceptions to the rule, laser up front. I mean, obviously, if someone's got a very, very high pressure, let's say 30 plus, you don't have time to wait for the SLT to work. So what I may then do is I might start them on medication, but simultaneously treat them with laser. And then depending on where they end up, I will then decide whether I think it's safe to discontinue topical medications and run them on laser alone.
Perfect. Right. Now, this is entirely different to what we're talking about, but Melbourne rapid field tests, what do you think of them? Sorry,
Melbourne who?
Melbourne rapid fields. It's actually a portable iPad way of.
Oh, that's certainly a left of field question. I think George is the man behind that. Can't think of his own name. Do you know his name?
George Hong and Algis Vingris, I think.
Yes. So I've heard about it. George has told me he was working on it. The last time I spoke to George about it would have been probably earlier this year, and I don't think he'd released it yet. So I really haven't seen it in action, and I don't know what to say to comment about it. Okay. Have you had experience yourself with it?
Look, it'll be too long to answer, but look, I understand there are good things about them, especially with COVID-19 situation where someone can self-monitor at home, but I'm not fully convinced of it just yet.
My old boss in Sydney was toying with an idea of putting something similar on the side of a bus stop so that people could do their own fields while they were waiting for the bus. And I think, look, the reality is that doing a field is an awful experience for both the person having it done and the person who's performing it. And if someone can come up with something that's easier and provides equal or better information, I'm all for it. But with this particular thing, I haven't seen George's thing in action, so I can't comment.
Okay. So I think we should probably go to presentation 2. And if there's any other question, we'll answer it at the end.
Okay, so just to make the comment that the second presentation is 2 studies combined because I think they belong together. It's not particularly long. It's about 9 or 10 minutes, and we'll break for questions after it.
Yeah.
Okay, we'll roll presentation 2. So I'm going to talk about 2 studies in combination because they're both treating the same problem, both the ZAP study and also the EAGLE study. So the ZAP study is the Zhongshan Angle Closure Prevention Study. And I'm going to give you an example like I did with the first presentation. So imagine this time that you're consulting and you see a patient who's 32 years of age and they've got the solitary finding of 180 degrees of iridotrabecular contact. So this is a patient who does not have an elevated pressure. He's got no other findings other than the iridotrabecular contact. And that's what this study, as well as some other studies that I'll present to you, thought to answer. What should you do in that scenario? So the LIGHT study was published recently, March of 2019, and came to this conclusion, which we're going to examine it more critically in a minute. The conclusion is that in view of the low incidence rates of outcomes that have no immediate threat to vision, the benefit of prophylactic laser iridotomy is limited, and therefore widespread prophylactic laser iridotomy for primary angle closure suspects, not primary angle closure, is not recommended. So in this particular study, there were 889 patients, and what they did is each patient had an iridotomy in one eye and was left untreated in the fellow eye. Now, the interesting thing about this study, which I think is its Achilles heel, is that patients who had a pressure rise on dilation or on dark provocation were excluded from the study. And you can rightfully argue that this is probably the majority of the patients who are going to go on to get complications. So by excluding this group of people, you highly likely are changing the outcome of the study. Now, in this particular study, the patients were followed for 72 months, but the outcomes were extrapolated out to 10 years. And what they discovered is that they had certain outcome measures that were outcomes that were undesirable, or failures, if you will. And these outcomes were that if patients developed a pressure of 24 millimeters or more on at least a couple of occasions, that was considered if you will, an event. If the patient developed 1 or more clock hours of PAS, that was also another event, an outcome. Or if they outrightly got an episode of angle closure. So these were the criteria that they were looking at, how many patients had this occur to them. So let's have a look at our findings. So the ZAP study concluded that over a 10-year period, the probability of progressing from a primary angle closure suspect, remember that's our patient at the beginning of this, to primary angle closure was 9%. However, let's look at another study, which is simply entitled Follow-up of Angle Closure Suspects, which was an older study published in '93, and which had 129 patients. And these were followed up with absolutely no treatment at all. They were just observed for the duration of the study, which was nearly 3 years. And what they found is that 25 patients out of the 129 developed an episode of angle closure. So that is a 19.4% versus our 9% in the ZAP study. Let's look at this more recent study, which is the 5-year risk of progressing, again, primary angle closure suspect to primary angle closure. And this was a little bit more recent in 2003. And what they found is that the 5-year risk of developing primary angle closure was 22%. So again, comparing with the ZAP study, 22% versus 9%. So I think you can see quite clearly that the ZAP study is a little bit out of keeping with what other studies have shown. The interesting other thing is that the ZAP study showed that an iridotomy halved the rate of an event. And this is my adding in, this is not a ZAP study finding, the cost is $660 for having the iridotomies. Now let's do a little comparison with something completely different, a patient with hypertension, not ocular hypertension, but hypertension. So if we take a 55-year-old hypertensive patient with a blood pressure of 150 on 90, they also have a 9% risk of developing a complication over a 10-year period, in this case an AMI. Now, treatment with an antihypertensive agent also reduced the risk, but unlike the ZAP study that reduced it by 50%, it only reduced it by 30%, and the cost was upwards of $3,600. How did I arrive at that number? Well, if you assume that the patient's treated with just one medication and they pay the average fee of $30 per month, that's $360 over a year, which is $3,600 over a 10-year period. Okay, so what about our patient, our primary angle closure suspect? What do we do given these findings? Well, let's look further at another study. And in this case, we're going to look at, you guessed it, the EAGLE study. So the EAGLE study is the effectiveness of early lens extraction for treatment of primary angle closure glaucoma. So not primary angle closure suspect. And this was published in The Lancet in 2016. And they found that if you've got a patient with primary angle closure or primary angle closure glaucoma, a clear lens extraction is more effective and more cost effective than a laser iridotomy and should be considered first-line treatment. So in this particular study, there were 419 patients and they were either primary angle closure or they were primary angle closure glaucoma. And if they were primary angle closure, they needed at least 180 degrees of appositional or synechial closure, but they needed an elevated pressure of over 30. And if they were a glaucoma, they didn't need to have such a high pressure, but they needed to have disc and field changes. All of these patients were 50-year-old or older, and they all had clear lenses, none had cataracts. So there were 208 patients who were randomized to get a clear lens extraction, and there were 211 that were randomized to get an iridotomy. So let's look at their outcomes. So the first thing, which is not at all surprising, is that those in the clear lens extraction had a better visual outcome. And that's obvious because there would have been a percentage of those that had a refractive error, and also even at age 50, you're going to have some lens changes. So removing the lens is going to give you better vision. Now, the need for further treatment was only 21% of our clear lens exchange patients, but 61% of our iridotomy patients. And the need for further surgical intervention, again, trabeculectomy, there was one patient only in the clear lens extraction group, but there were 24 in the iridotomy group. The differences between pressure controls were really not that different. They were very similar between the two groups. Okay, so now that we've got some additional information, we go back to our primary angle closure suspect patient. What do we do? Well, I think we will have to agree that based on the studies, the most likely risk of this patient progressing over a 5-year period is about 20%. So my take, and this is the take on of my colleagues, is that until guidelines officially change, if you come to me and you've got primary angle closure, you're a primary angle closure suspect with more than 180 degrees of iridotrabecular contact, we're going to do an iridotomy. Now, some of my colleagues have said they're going to follow them more closely. Some have said they're going to do it at 270, but the majority have said there are no guideline changes and there is a significant benefit, therefore we'll still do an iridotomy. If they're a primary angle closure and they're older than 50 years old, I'm going to offer them a clear lens exchange. If they're a primary angle closure under 50, I'm probably going to offer them an iridotomy, but if they are motivated to deal with their refractive error, if they have one, or if they've got any cataract, I'm still going to discuss lens extraction with them. And if they're primary angle closure glaucoma under 50, my approach will be very similar in that, again, I'm going to offer iridotomy, and obviously they're going to need pressure lowering treatment as well. But again, if they've got a significant refractive error or a degree of cataract, I'm going to offer clear lens exchange. Okay, so that comes to the end of these two presentations. We're now going to turn over to Will for any questions.
So, Joseph, we've got a few questions from the previous presentation, but none coming from this one just yet. So while we're waiting for the next one to come, I'm just going to ask the question that's raised by both Lynn and John. So with regards to SLP, should we start telling all the glaucoma patients that we refer that may need treatment or that will probably need treatment to be prepared for SLP?
Look, I think that's probably not unreasonable, although at the end of the day, I'm still going to have a discussion with the patient as to what their preference is. But invariably, most patients are going to turn it back to me and say, well, I'm not the doctor, what would you recommend? And I'm going to weigh it up. I mean, again, as I said before, how you treat a patient who comes in with a pressure of, say, 25 versus someone who's got a pressure of, say, 35, and how you're going to treat someone with minimal disc changes versus someone with a lot of disc and field changes. They're going to be quite different. So there's going to be some people that I just know SLT alone won't treat them, and I won't even go there. I'll probably start them on topical medications and maybe supplement it with SLT later on as a means of minimizing medications. But generally, if they're, say, 25, a pressure of 25 or thereabouts, and they've got some obvious glaucoma, I'm going to offer them SLT. So I think you should say you're probably going to get SLT, but not necessarily. And this is, again, where you need to be involved and say, gosh, given your set of problems, probably Joseph is going to start you on medications, or he's going to start you on SLT, depending on how you assess that particular patient scenario.
And John's question was, after SLT is performed, what would be your monitoring regime with the patient? And if you were to co-manage with your with the referring optometrist, what kind of intervals do you want us to see the patient at?
Okay, so my concern at the moment with SLT is I have no idea how long it's going to last before it wears off. I don't know that pressure fall that I see at, say, a month is going to be still there in 3 months. So at the moment, I think most of us are kind of figuring out what we're going to do. But what I'm currently doing is I see them at a month after the SLT, because that's plenty of time for those late responders to respond. And then if they've got a good fall, I'll say to them, would you mind popping in about 3 months just so I can really convince myself that you're actually going to stay there? And then once I'm confident, then I think I revert to the normal follow-up regime. And currently guidelines recommend that you have a 6-month follow-up. So who does what depends on the patient, where they live, and so on and so forth. In the country, I tend to pretty much leave it to the optometrist to manage, and I see them once a year or whatever frequency the optometrist prefers. And in the city where they're a bit more accessible, I tend to see them at 6 monthly. But again, it depends on the optometrist, and everyone's got a different preference.
Perfect. Okay. So this is now with regards to the second presentation. So if someone has iridotomy, how frequently should they be monitored for further angle closure progression?
Again, this is one of these how long is a piece of string type questions. My practice is I do the iridotomies and then I review them after the iridotomies to see, has the angle changed? And the reality is that most of the time I don't see a lot of widening, but sometimes you do. And then my usual practice, which is currently in flux, is to see them at a year. But again, it all comes back to the optometrist involved in managing them. Like, for example, if I know that you send me a patient and I know that you're going to be interested in following them up, I might say to them, see Will in a year and see me in 2 years. There's no hard and fast rule. We don't have clear guidelines, and it will be very much governed by who the optometrist is. I mean, sometimes there is no optometrist involved.
Yeah, excellent. So one of the other things that I've always been curious about is, if you do PLI and there is no change in angle configuration, has their risk been lessened by having that PLI done?
Well, again, I come back to the study. The study has shown overall that if you do an iridotomy, you're halving the rate of developing primary angle closure or primary angle closure glaucoma. So you've got to follow the studies for guidelines. Just because you haven't had a widening doesn't mean anything, because in that study, you can imagine there would have been a number of patients where the angle configuration hasn't changed and others where it has. And that's hopefully all come out in the wash, so to speak, because the numbers of the study were large enough. So in my mind, it doesn't put me off. I know that their risk is reduced. Unless there's another reason, I don't do anything else. I know there are people who will say, your angle hasn't opened enough, therefore we should do a lens extraction. The reality is there's no clear evidence for that, at least not in a primary angle closure suspect.
Perfect. Thank you. Should we go for the third presentation? And
so this
there'll be more questions coming our way.
Okay, this is our last presentation. It's probably the quickest, and to me, quite an interesting thing because it's caused me to change my mind. Okay, our final presentation for the day, and I promise you it will be quick. about 8 or 9 minutes and will be useful. So this is the FEMCAT study, or at least this is these findings are based on the FEMCAT study, but also a number of others, which I'll show you as well. So in this patient scenario, you've got a patient who needs cataract surgery and they ask you, should they have cataract surgery with laser-assisted, femto laser-assisted cataract surgery? And they add that they think that it's better because they've read that it's better, but also it's more expensive, so therefore they conclude that it must be better. The first Australian femto machine was installed in Sydney in 2011, and I became so convinced that it was the way of the future that I was myself planning to buy a machine, but I didn't really need to, because in 2012, Victoria Parade Surgical Centre, where I do most of my surgery, decided that they wanted to provide the latest technology to their surgeons because they wanted to be a cutting edge centre, so they installed the machine. So effectively, I've been performing, as well as conventional surgery, femtosecond laser cataract surgery for about 8 years. Let's have a look at what our goals of surgery is in an attempt to answer our patient's query. So the goals of cataract surgery, or in brackets refractive lens exchange, are broadly, you want excellent vision. If that patient is capable of achieving 6.4.8 or 6.6, either unaided or aided, you want to achieve that. So you want technology that gets you excellent vision. You also want to achieve your refractive target, whatever that target may be, whether it's emmetropia, whether it's myopia, whether it's monovision. And by achieving targets, I think most people would agree that the best practice these days is you should be able to get people within a diopter of your goal. But in fact, with current technology, it's probably even common to be able to get them within half a diopter of the goal. And furthermore, you don't want complications. So we need to look at whether this technology meets these goals. So the FEMCAT study was published in January of this year, and it had 1,476 eyes, of which 704 got femtosecond laser-assisted cataract surgery, and 685 got phaco. So the first question that this study addressed is, are visual outcomes better with phaco or femto? The second question is, are refractive targets better achieved with one versus the other? And is one technology safer than the other? Is it safer to do femto, or is it safer to do phaco? And this is the conclusion of the study. Despite its advanced technology, femtosecond laser was not superior to phacoemulsification. Now, please take note that it is not inferior. It simply has higher costs. And I know there's a lot of ophthalmologists, not ophthalmologists, a lot of optometrists who are very opposed to femto. I don't know why anyone would be opposed to it, because it's certainly not going to give you inferior results. The most you could argue, it's not going to give you better results and it's going to cost more. So if the objection is purely cost, I get that. But apart from that, it's certainly not inferior. Let's have a look at this study, which is a meta-analysis. So this is a whole lot of studies looked at comparing femto to conventional cataract surgery. And this study was also published in this year, in 2020, Journal of Cataract and Refractive Surgery. And the conclusion is that they're both safe and effective, but that femto required much less ultrasound energy and was more precise. However, that did not really translate into any great difference between either method. Let's look at this study here, which basically was done by people that you know, and is looking at changes in the endothelium, given that we know that femto has less energy, done by Nathan Kerr, who, as you know, is a glaucoma specialist in Melbourne, Penelope Allen, who is a VR surgeon in Melbourne, and Brendan Vogt, that you probably don't know, who's a VR surgeon in Hobart, who has invested in one of these machines and has performed lots and lots of surgery and published extensively on the subject of femto. The study came out in 2014, and its conclusion was that it was significant reduction in corneal edema and significant reduction in endothelial cell loss compared with phaco. However, this difference did not really hold up with time, so that with the passage of time, both groups of patients had a good outcome. Let's have a look at the FACT study. And the FACT study came out in 2020, and it also concluded that femto was definitely not inferior to conventional surgery. Both methods are good in terms of visual outcomes and in safety. But again, questions the cost effectiveness of it. And a final study, which is again looking at endothelial cell loss, but also looking at refractive predictability, published in 2019, it concluded that endothelial cell loss was significantly lower with femto compared to conventional, but basically said, if your patient has got a normal healthy endothelium, there's really not a lot to be gained because these patients can comfortably afford to lose some endothelium and it doesn't negatively impact on them. So if you've got a patient whose endothelium looks a bit like this, they're either Fuchs or some other sort of endothelial dystrophy, you might want to recommend femto. If your patient's got significant PXF and you can see that they've got zonular dehiscence, or if in fact they clearly have zonular dehiscence, again, you might want to recommend it. Here's a video to show an attempt at a capsulotomy, and you'll see these striae forming because the capsule is loose due to the loose zonules, and any attempt to try and do a capsulotomy is going to result in further zonular dehiscence and potentially loss of that lens. Compare that with doing a femto, which, as you can see from this video, takes about a second to, or even under a second to perform a capsulotomy. Therefore, there's going to be no tearing of any zonules. Also, if you've got an intumescent dense cataract that you try and open the capsule and you end up with the famous Argentinian flag sign where the capsule just rips out and therefore means that you're likely to lose that lens. Here's another example of that to show how dramatic it can be. Just merely touching that capsule causes a tear out. Again, as you can see, doing a femto takes less than a second. So if you've got that intumescent lens, it isn't going to tear out. So given these studies, this is my approach now. I no longer offer it routinely because I can see that it's really not that much better except in specific cases, and it's definitely not cost effective. I would offer it routinely if the cost dramatically dropped. If I've got significant PXF and I can see zonules are loose, I offer it. If I can see the zonules are loose, I offer it. If there's significant endothelial disease, I offer it. Although even there, by doing techniques such as single port, as opposed to what most surgeons do, which is 3-port, and by doing pre-chopping to minimize phacoenergy, even there, I think you can get a good outcome with conventional surgery. But certainly if they've got a dense or an intumescent cataract where the risk of ripping out is high, I'm going to offer it as well. And that basically brings us to the end. And we're now going to turn back to Will, where we're going to take questions on any of these 3 presentations.
Joseph, can you describe the difference in the effect of SLT on pigment dispersion glaucoma or pseudoexfoliation glaucoma patients?
Okay, so let's talk pseudoexfoliation first. So there are a number of conditions that are the so-called quintessential diseases that you would want to treat with SLT, and that's PXF's one of them. So as a general rule, one of the most responsive conditions is definitely PXF. Now, as far as PDS goes, that's a slightly different subject. The problem with doing it in a pigment dispersion is that you run the risk of having a paradoxical pressure rise. So you really want to be very careful doing an SLT in a patient with pigment dispersion. And in fact, I often tend to shy away from it. I've got a patient at the moment who's got pigment dispersion that I've been treating with topical medication, and she's reached a point where she's really not responsive. And I said, look, we're going to do an SLT, but I've warned her, and she's done a lot of reading herself, and she knows that that might result in a very high pressure spike, which could theoretically end up in doing something like a stent or a trabeculectomy. So PDS, I tend to shy away from it unless the patient really doesn't want topical. PXF, I strongly encourage it. And obviously all the other ones, I do use it. It's a little bit controversial in a narrow angle. And what people kind of say is, if you can see the angle well enough to put it on, there's no reason why you can't.
Perfect. And while we're at it, there were rumors about different colored iris and the effect SLT has on different colored iris. It's been proven to not to be true. Am I correct in saying that?
That's correct. There's no real difference. I mean, there's certainly a difference in trying to do an iridotomy on a different colored iris, blue versus brown, for example. But as far as treating the angle goes, the color of the iris, to my knowledge, I've not read any convincing paper that says there's any great difference.
Perfect. And we've got a question from Claudette. She wants to know when you would recommend lens exchange in cases of angle closure risks. And I think that's because optometrists, we do see a lot of hyperopic patients with narrow angle. And at what point would you say, look, clear lens extraction is the way to go?
Okay, so remember that the data that we've got on this subject is limited to patients who are over 50, who have a clear lens. We can't really comment in other groups, but intuitively, if you've got a patient who's a high hyperope, as an example, then and is motivated to do something, whether they've got a cataract or not, there's no question that doing a clear lens exchange or a cataract surgery is definitely going to help that patient. And there's also some evidence that if you've got a primary open angle, so a patient whose angle is completely open, there's no question that doing a cataract procedure is going to lower their pressure. And if you decide to combine that with, say, an eye stent or a hydrus or whatever, you're again going to get gain. So again, that's a group that I would talk about doing cataract surgery if appropriate.
Excellent. And so far, there's no answer from Medicare whether someone who basically needs earlier surgery could be covered because it reduces their risk. Is that right? At the moment, there's no talk on.
That's correct. The Medicare ruling basically says if you have a cataract and if you're having cataract surgery because of visual reasons, then that's fine. But if you do not have a cataract and you are planning to do this because the Eagle study says it's a good thing to do, technically we're not covered. So it's a bit of a gray zone to do.
Yeah, and I think you said it best that we shouldn't, or David Southgate, who spoke to me the other day, he said, like, you shouldn't confuse what Medicare would like to pay and what best care for the patient would be. They're often two different, isn't it?
That's right. I mean, the reality is that there's no question in the scenarios presented in the Eagle study that doing a clear lens exchange is a good thing to do. It's a little bit more, a bit of a grey zone if that patient's primary problem is primary angle closure or primary angle closure glaucoma and they've got some cataract. You could argue you're doing a cataract operation, but technically your motivation is not really because of cataract. So if you're going to follow the spirit of Medicare, you probably would have to say you can't really do it. But I think the reality is most people would say it's going to be in your benefit. You do have a bit of a cataract. We'll do it anyway, whatever the Medicare ruling says. Although bear in mind, the Medicare ruling isn't that specific. The Medicare ruling doesn't, if you read the guideline, it doesn't actually say cataract extraction. It says lens extraction and insertion of lens.
Yeah. Okay. So one open question remaining. Do you do things differently in COVID times?
Not really. I'm not sure specifically what that relates to, but not really. Surgery is essentially back to normal. Managing my usual patients is not that different to previously. I think our practice has not really had any real change other than surgery hasn't been happening because all centres have been closed. Other than everyone wearing masks and maintaining spacing in the waiting room, there's really nothing else we're doing different.
Yeah.
I'm not aware there's anything that you could do different to manage the diseases that I manage.
Thank you. Now, is there any other questions or should we? I'll continue with a few questions that I've thought was quite interesting. So, you mentioned earlier about the preference of optometrists or referring optometrists not starting treatment if they were going to refer. So is that something that is shared by a lot of ophthalmologists?
Yes, I think
Or
most
is that your
ophthalmologists.
view?
No, I think I speak for what most people think, that if you're sending me a patient and forget glaucoma, any problem, it's far better to see the patient in their natural state, as if you will, so that you can assess them and decide what the appropriate treatment is. If you send me someone and you say to me, I found their pressure to be high and I started them on medication, and I examine them and their pressure is normal because they're on medication, and I don't find anything else, it's kind of hard for me to know what to do. So I will often stop their medication just to see what happens. I will often get them back, say early morning, do a couple more measurements, and then come to a conclusion as to what to do. So preferably, not just me, but most ophthalmologists would say, please don't treat them, except in the exceptions that I gave before where it's appropriate to treat them. Like their pressure is really crazily high, or their nerves really very cupped out and you just don't think they can afford to. Other than that, I'd prefer, please don't treat. They can always wait a day or two or even a week.
Perfect. Okay, so we're almost close to the end. So if there's no more questions, we'll close this session.
Okay.
Is there any question?
Nothing else? No one's coming up with anything? All right, well, I'd like to thank all those who attended, and I also would like to thank B&L for sponsoring this seminar, which I thought was important.
Thank you.
Okay.
And thank you, Joseph, for doing all this too.
Okay, fantastic.
Okay.
Thank
Bye,
you very
everyone.
much, guys. Fantastic presentation. See you next time.